so much for joining. Thank you all so much for joining us tonight for Bicycle Health's first open house. My name is Kyle Young. I'm the trainer for the Enrollment Department. I will be your host for the evening, and I, along with the other speakers of tonight's events, am very excited to speak with you all about Bicycle Health, the services that we provide, and the lives that we're saving every day. So thank you so much for taking the time out of your busy lives to learn more about what it is that we do. So before we get started, I would like to just go over a couple of disclosures before we get started. So firstly, please know that the presentation is being recorded for quality assurance and training purposes. Secondly, this presentation is not intended to provide any type of medical advice and is intended only to provide the public with an overview of Bicycle Health, our program, and how it works. So during this open house, we will offer individuals suffering from addiction and their loved ones an opportunity to connect with providers, recovery coaches, and other staff of Bicycle Health from the comfort of your own home. Attendees of this event will gather information from speakers regarding program details, what Suboxone is, how it works, and the success rates of patients using Suboxone for their recovery, next to other treatment methods. Attendees will also learn about Bicycle Health and our services and what sets Bicycle Health apart from other addiction clinics. So our agenda for this evening is as follows. I'm going to begin by giving you all an introduction to Bicycle Health and how and why Bicycle Health was created. I'm then going to bring in our guest speaker, Sarah Howroyd, to talk with us about the connections between mental health and addiction. We'll also hear from a Bicycle Health clinician and a member of Bicycle Health's care team to discuss what Bicycle Health's managed patient care looks like while being an established patient. Another topic that we will be covering this evening is what that process looks like to enroll into the Bicycle Health program. From there, we'll go through a brief tour of the Bicycle Health app, where you'll be able to learn how the app works, what it does, its different functionalities, and really just how user-friendly it is. I'm then going to conclude the open house with some time for some questions from you all. So if you do happen to have any questions or concerns along the way, please feel free to utilize the Q&A functionality within this Zoom meeting. And one of our top enrollment coordinators, Robin Carter, is with us to help answer your questions. We also have Q&A help from Gina Bompadre, one of our clinical support specialists, and Dr. Julie Craig, one of Bicycle Health's top clinicians. If you notice the image on the right, all you need to do is select that little Q&A icon that's in that little green box toward the bottom of your Zoom video, and the Q&A pop-up should appear, which should enable you to type in whatever question, concern, comment that you may have. So let's get started. So why are we called Bicycle Health? So when our founder was developing our organization, he found a lot of similarities between addiction recovery and riding a bike. You have your uphills, you have your downhills. You can move slow or you can move fast, depending on your choice of speed. Many times, you start out with training wheels until you feel comfortable riding the bike without them. And sometimes, without those training wheels, we fall off, and that's okay. The goal is to get back on that bike, keep going, and not let that fall deter you from riding the bike. Bicycle Health was started about 5 years ago by our founder and CEO, Ankit Gupta. An engineer by training, Ankit wanted to create technology that had impact and meaning, and realized that there was a huge need to help people suffering from addiction. At the time, fentanyl and other opioid addiction were skyrocketing, so the organization decided to focus treating opioid addiction specifically. After spending several months connecting with people in recovery and listening to their stories, he began building Bicycle Health Treatment Program. Bicycle Health began as an in-person treatment center in Redwood City, California in 2019. The first clinic had about 8 staff members and about 150 patients. The clinic was successful, but to make it easier for patients to access care, the organization decided to start seeing patients via telehealth as well as in person. It quickly became apparent that much of the stigma that came along with addiction evaporated in a telehealth environment, and it became much easier to positively impact the lives of our patients. Telehealth made things like caring for children or an elderly loved one easier, and it also made it easier for people to stay employed and seek treatment that fit their work schedules. Travel often impacted treatment as well, along with privacy concerns. Telehealth fixes all of these problems. So what is telehealth? Telehealth is the delivery of healthcare remotely by means of telecommunications technology, meaning telehealth allows a healthcare provider to care for you as a patient without any kind of in-person office visit. So when COVID-19 hit, Bicycle Health converted to 100% telehealth, and we never looked back. Converting to a 100% telehealth treatment program was a complete game changer for our patients. It enabled us to provide high quality treatment from anywhere in the country. In 2 years, Bicycle Health has gone from 8 staff members to just a little over 200. We've gone from serving patients in just 1 state to being licensed to treat patients in about 30. And most importantly, we've gone from 150 patients to just around 18,000 patients. Bicycle Health is HIPAA compliant and is one of the only telehealth companies that employ full-time clinicians and on-call teams. In 2022, Bicycle Health was listed as one of Time Magazine's most influential companies. Our mission is to increase access to quality, affordable, convenient, and private opioid use disorder treatment for all. And our vision is to enable anyone with a chronic disease to live a healthy and fulfilling life. So, as mentioned before, we are currently licensed to treat in 30 of the 50 states. The green on the map that you see indicates the states that we are presently active in, and we are working diligently to get the rest of this map filled up with green. So, let's get into it. I would like to introduce to you all Sarah Howroyd, who happens to be the Director of Behavioral Health here at Bicycle Health. She is going to speak to you all not just about opioid disorder, which is sometimes otherwise known as OUD, but also about the connections between opioid use disorder and mental health struggles. So, thank you so much, Sarah, and feel free to take it away.
Thank you, Kyle, and thank you for your leadership in putting this together. It's been so awesome working with you on this. So as Kyle indicated, my name is Sarah Howroyd. I'm the Director of Behavioral Health. I am also a licensed clinical social worker and loudly and proudly a woman in long-term recovery from opioid use disorder. So to clarify, I always like to start out by clarifying what I'm talking about. So I want to talk about the definition of addiction. So the APA defines addiction as a complex condition, a brain disease that is manifested by compulsive use despite harmful consequences. Society has done a great job of arguing if opioid addiction is a disease or a choice, and I often will always say that if it were a matter of a choice, we would cure ourselves, right? We would muster up our willpower to cure ourselves, but it's not that simple. As a social worker, I often, when working with people struggling with opioid use disorder, will look with them at their life and are they living their best life? Are they working? Are their relationships fulfilled? Are they parenting? Or are all of those avenues of their life between their behavioral health needs, their physical needs, and everything else, are all of those aspects thriving? Are they really living their best life? And if the answer is no, we might want to explore and look at what that might mean. And I also want to add that even though our work focuses primarily around opioid use disorder, addiction is a disease that goes way beyond alcohol and drugs. It can also encompass pornography, gambling, shopping, food. I know every morning I wake up and the first thing I check is my iPhone, right? We all face some form of addiction in our life. It's just a matter of when it starts to become problematic and disrupting other elements of our life so that we're no longer living our best life, that we might want to look inward and explore the reasons for that and how to get things back on track. So addiction risk factors. There are protective factors and then there are risk factors. So protective factors keep us safe from problematic events, where risk factors can increase the likelihood of addiction occurring. This is not an exact science. We know that some of this is starting to be researched better, but stigma and lots of other issues have slowed down research on this for a long time. Just because a person has one of these risk factors does not guarantee that they'll go on to develop addiction. Someone could have all of these risk factors and not go on to develop addiction. We know that genetics is a big factor, but we haven't pinpointed an actual addiction gene, and we don't know why it skips some siblings, it skips some generations. We know that it runs in families. And beyond that, looking at the other addictions beyond just opioid use disorder, if we look at within our own families, it's usually common that some form of addiction can run there. Also, early exposure to substance use. We know that people who start earlier, often their brains can stop developing at that time. If you start in your early teenage years, our brains develop until our mid-20s for men and our early 20s for women. And so if we started using substances regularly in our early teen years, it can be very difficult to later stop, and more like we're dealing with some of the brain chemistry of that of a teenager, even though we may be older in life. Trauma and high anxiety in childhood. We know that traumatic events and high anxiety in childhood can increase the likelihood for people looking for other coping factors. Presence of mental health issues. That's what we're going to talk a little bit more deeply about tonight. Many people who struggle with opioid use disorder may struggle with other mental health issues. And then peer pressure. A common prevailing saying within 12-step communities is if you hang out for long enough in a barber shop, you're going to get your hair cut. And so all of these are factors. Again, it's not an exact science and it's not guaranteed one way or the other, but we know that all of these things can increase the likelihood of a person struggling with opioid use disorder. So approximately 8.1 million adults in the US have co-occurring issues, and this constitutes more than 40% of people living with substance use disorders. So mental health issues and opioid use disorder. Mental health and substance use disorders, which is kind of an umbrella term for all substance use disorders, including opioid use disorder, often occur together. And this is because certain drugs can cause people with addiction to experience one or more symptoms of a mental health issue. We know that chemicals can, in frequent chemical use, can create a replica of mental health issues, but it may not be clear if it's a result of the addiction or it's the result of mental health issues. We also know that many people, and due to stigma and shame and misunderstanding, may self-medicate. So perhaps there are some people who struggle with anxiety or depression and start self-medicating at a young age. And it's not clear whether it's the substance use or it may be an underlying mental health issue. We also know that mental health and substance use disorders share a lot of the same underlying causes, from changes in brain composition, genetic predispositions, and early exposure to stress and trauma. So individuals diagnosed with substance use disorders, including opioid use disorders, are more statistically likely to struggle with mood disorders, anxiety disorders, potential personality disorders. I often will have noticed the triangle in my own practice of women who struggle with ADHD, eating disorders, and addiction. I feel like that triangle is pretty prevalent. And that often is an issue surrounding impulse control, right? We know that the prefrontal cortex, which is kind of the brakes of the car, we know that people who struggle with addiction issues and other mental health issues don't always have the best impulse control. And part of that is continual drug use can make it difficult to pump the brakes, right? We also know that bipolar disorder, ADHD, PTSD, schizophrenia, all can be in combination with substance use disorders. I think it's important to mention this. It's something I anecdotally, in my own travels of recovery, started to see going on 20 years ago. I started to notice that there were people who I knew before they used substances who otherwise didn't struggle with depression or suicide attempts or suicide completion. And I noticed a theme, and there's been research coming out in the last couple of years, especially surrounding the VA and the Veterans Administration, tying in suicide, depression, and the struggle that a lot of us faced when we were first trying to get sober, right? I know so many people who so desperately want to stop opioid use, but just physically and emotionally feel so horrendous that they initially cannot. We know that people who use opioids are 14 times more likely to die by suicide. And that this is the gravest of odds for all substances. We also know that lifetime suicide attempts for people living with OUD is elevated. But why is this? So the biggest factor is often the shifting brain chemistry and the composition. Addiction can very quickly no longer be fun, right? So for those of us that are trapped in that vicious cycle, feeling horrendous and feeling really awful can be a big part of that. Our brains stop making the feel-good chemicals that many of us who may not have struggled with addiction have felt. And so it physically and emotionally can feel really horrendous. Shame, stigma, the wreckage that a lot of addiction can cause. It can cause, for when someone starts to come off of substances, the wreckage can feel insurmountable. It can feel like it is such a high mountain to climb and that is next to impossible. We can face physical ailments, mental health issues, loss of job, family, relationships, money, housing, possible criminal justice involvement. And there's often a long list of things that we need to clean up once we try to enter the recovery process. But on the other side of that, opioid use disorder is a chronic, progressive, relapsing disease that is also very much preventable and very much treatable. People with OUD can go on to live and do really remarkable, incredible things and live happy, productive, healthy lives with really meaningful relationships and being productive members of society and within their communities and within their families. And there is a solution for opioid use disorder, and Bicycle Health has supports, treatment, and services that is one of them. I want to close with the working definition of recovery. We really pride ourselves at Bicycle to be empathetic and compassionate and to treat everyone we encounter with a tremendous amount of dignity and respect. It's often something I hear from our patients that they've never been treated like this in a treatment setting where people are just so kind and compassionate and non-judgmental. And we are really big on that. And another thing we're really big on is letting people define recovery on their terms. So working definition of recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And we defiantly have hope in all of our patients at Bicycle Health. We do not give up easily. And again, the process of recovery, even in my own situation, was the hardest thing I've ever done, but it's also the most rewarding and most fulfilling thing I've ever done. And I want to thank you for your time tonight. And Kyle, thank you I'll pass it back to you.
Awesome. Thank you so much, Sarah, for that really good detailed information. And I think it's really educational and a topic that society really needs to feel, a lot more comfortable talking about. So thank you so much again for your time and in the information that you were able to provide for us tonight. You're the best. All right. So I would now like to bring on one of our top clinicians, Dr. Julie Craig, and one of our clinical support specialists, Gina Bompadre. Dr. Craig is going to speak about our clinical model and touch on what Suboxone is and how it works. Gina is then going to take over, and she'll be speaking with you about what it's like to be an established patient with Bicycle Health. So without further ado, I would like to introduce you all to Dr. Julie Craig. Hi, Dr. Craig.
Hi, my name is Julie Craig. I'm one of the medical directors, regional medical directors at Bicycle Health. I'm in the Pacific region, which is California, Oregon, Washington, Nevada, and hopefully someday, if their regulations are amenable to it, Alaska and Hawaii also. Kyle, do you want to go ahead and switch the slide there? So what I'm going to talk about is the medications that we use to assist with opioid use disorder. So we primarily use a medication called buprenorphine, which is mixed in with naloxone, which is simply there to stop people from injecting it. There's no other reason for naloxone to be there, which is commonly known as a brand name Suboxone. It also has a number of generics these days. Buprenorphine is what's called a partial opioid or partial opioid agonist. So it fills the opioid receptors, but it doesn't activate those receptors. So it stops the cravings and the withdrawals that go along with opioid use, but it doesn't have some of the dangers that go along with opioids because it doesn't fully fire off those receptors. So for example, one of the advantages, it's safer. We don't see overdoses with Suboxone in the way that we do with opioids because it doesn't fully fire off those receptors. So if somebody takes a handful of Suboxone as an adult, it really doesn't do a whole lot beyond what the first or second dose of a therapeutic dose would do in a day. The next reason we use Suboxone is because it's long acting. It should last about 24 hours in most patients. Sometimes we split it to every 12 hours. And that long acting nature helps people to focus on their lives rather than focusing on constantly having to step away from other activities to dose, to always have a supply ready of opioids. And the third reason we use Suboxone is because it does not cause tolerance. Tolerance is the need to have more and more opioid over time. Same with some other drugs like Xanax and things like that to get the same effect. So with Suboxone, if we can stabilize somebody on a reasonable dose, which is usually 8, 16, at most 24 milligrams, they usually stay at that dose. If we need to go up for some reason, it's usually because something has changed. There's a new injury, a new illness, something very stressful has happened in their lives, something like that. But for the most part, we don't see that effect that we see in opioids, where people need more and more and more and more over time, which is the natural history of opioids. Even if somebody's taking it appropriately for pain from a prescribed source, opioids in just about everybody will cause this tolerance. Now, there is a big disadvantage to buprenorphine, and that is that it maintains physical dependence. So if somebody stops buprenorphine suddenly, they're going to feel it, and they're going to feel it much in the way they feel opioid withdrawal. We use it because of the reasons above, because it's safer, because it's longer acting, and because it doesn't cause tolerance. Now, some people say, well, are you just trading one drug for another? And I would argue that the way to answer that question is to ask the friends and family who surround somebody who was gone on to buprenorphine. How do you see that person now versus when they're using opioids? Most people say that person's back engaged with their family, they're back at work, they're able to focus, they're not constantly having to deal with finding and taking opioids, nodding out, all those kinds of things. So yes, it does maintain a physical dependence, but we don't consider it trading one drug for another. We consider it recovery. So the medical model that we use with Bicycle Health has several steps to it. Induction is the process of going from opioids to buprenorphine. Because buprenorphine sticks very tightly in opioid receptors, if you just take it on top of any regular old opioid, whether that's heroin or oxycodone or fentanyl or anything like that, it will kick out the opioid and cause what's called precipitated withdrawal. Precipitated withdrawal is not pleasant, but it's also not dangerous. But we do want to help people avoid it. So with that first induction visit, we go through the process of getting onto Suboxone from opioids. We see people frequently. Sometimes that's every day. Sometimes that's every third day, depending on how complex the induction is, what other conditions exist. And we give comfort medications to help people through the withdrawals that they need to go through in order to make that induction. We also have providers who are on call 24/7. It's not always me. It's often me, one of the zones. But if somebody needs something goes wrong in the middle of the night, we have people who can answer if they reach out through the app. Once somebody is on Suboxone, then they're in maintenance. That might mean dosing adjustments to try to figure out the best regimen for that one person, which is different for everybody. Monitoring for treatment success, which is drug screens and things like that. We use home drug screens. We send them to people's homes. They do them in the privacy of their own home and upload real-time photos through the app in a structured way. But we also have the ability to send people to labs. We know that people have many reasons to feel like they can't be honest about what's in their drug screens. For the most part, our policies, we want to know what's there because we want to be able to help. Most of our providers are pretty comfortable with treating secondary substance use disorders like cocaine, methamphetamines. Now, there are some that are not safe to treat in this setting. One of those is benzodiazepines or sedatives, and another one is alcohol. So we're very cautious about that. But for the most part, if somebody's having a secondary issue, we want to know about it, find out the root causes, and address it. We also want to address other issues that cause the opioid dependence, and those can range from not a whole lot. Some people just like opioids, and that's probably part of the genetic piece of it. They try it once, they just kind of like it and kind of stick with it long enough to end up having problems with it. But many patients also have underlying issues that drove them to opioid use or have kind of developed as a result of opioid use. So anxiety, depression, insomnia, PTSD, ADD, those are the things that I want to address before I even think about taking somebody off of Suboxone, which is kind of a lengthy and slow process. So we address all those issues. Now, if somebody has really complex psychiatric issues, we send them to outside sources. We don't have psychiatrists. So if somebody has delusions, hallucinations, mania, thing that we want a psychiatrist to be involved with that and to be treating that side of it. We treat relapse. Relapse is a part of the process. It's not something that we consider shameful or stigmatizing or a reason that people need to leave care. Now, if somebody relapses all the time, which sometimes people say, well, I relapsed on Monday and then there was Friday and also like Sunday morning, that's more like continuous use than relapse. We may send somebody to a higher level of care, and that might mean residential for a month. It might mean a more monitored situation. It might mean the same medication, but with intensive outpatient at the same time. And we use this team-based approach. So we engage with behavioral health. Now, not everybody needs behavioral health support. We do have a lot of patients who simply took pain meds for too long for a legitimate pain condition and found that, as everybody will eventually, they got the tolerance to it. They need more and more over time. They start to run out early and run into trouble with their physicians or other providers because of that. But a lot of our people who are in treatment with us really can use some extra help. So we do engage with behavioral health. We have peer support coaches, Sarah and her whole team. And with that, we try to address all these underlying issues. Now, some people eventually will want to taper off Suboxone. It's not for everybody. There are certainly people who are in our services who will be on Suboxone for life, and that is their choice. It's not a choice that we make for them. Typically, those are people who with either severe chronic pain, where they're doing fairly well with the pain relief aspects of Suboxone, and they want to stay on it for that reason, or people who have off a number of times and really not done well with it. All these services are online in the privacy of the patient's own home or their own setting. I've done intakes with people stepping out of work for lunch, sitting in their truck, have privacy. I have done, visits where people are sometimes not the best places, but, stepping out of school, in the privacy of their own home. We can do visits anywhere where people have privacy, a good Wi-Fi connection, and the ability to have a robust conversation about what's going on. Overall, studies show that medication-assisted treatment saves lives. That is unequivocal in the data. And Bicycle Health, our job is to make that treatment convenient and accessible. And I'm going to hand it over to Gina.
Couldn't find the mute button or the unmute button. Hi, everybody. Thank you, Dr. Craig. Sarah, Kyle, this is just amazing to have something like this put together so that we can share with so many more people. Again, my name is Gina, and I am a clinical support specialist. If you can say that 5 times. I work in the Northeast region, so kind of basically Michigan on over to the east. And I'll get to more into what all that means for you in a moment. But I just want to tell you, through this program, our patients, you, like Sarah has mentioned before, you're going to be able to live your life. You're going to be able to maintain employment. We've seen people get promotions and rebuild those relationships that they thought, that were just gone and lost, but it's not, and we're here for it. We're here to help, and we are in your corner every step of the way. Having this program via telehealth allows you, like Dr. Craig said, to have your appointment where it's comfortable for you. And if that's in your own home, if that's, stepping away while you're at work to have a conversation with your doctor or your provider, where whatever's going to be the best for you, that's what we're here for. Now, after you've enrolled into the program, your first appointment is scheduled, you're going to get a link to download the Bicycle Health app. This app is actually all that you need to have your appointments and to reach your care team. While that process is happening behind the scenes, your care team, people like me, the clinical support specialists, we're calling your pharmacy. We are making sure that they have stock in this medication for you. We know that this is going to be a little bit of a tough time for a lot of people. So our goal is to make the transition as seamless as possible for you. So by locating this ahead of time, it prevents a delay in your induction and reduces the time spent kind of trying to go back and forth, with your care team. So you got the app, you got your appointment, you made your appointment, you did it. You did it. We know that that was such a huge step that you just took, and we are so proud of you. Your provider went over during your appointment how to start the medication and gave you the induction plan like Dr. Craig talked about. If you have questions about this or anything, the app is the best place to reach us. The clinical support specialist, also your care team is what we're called. Have you ever been to a doctor's office? The nurse or the medical assistant calls you back, asks you a bunch of questions, gets your vitals, and then passes you off to your provider? Well, that's what we are. Every patient is assigned a care team, and we can help with 90%-ish of whatever your needs are. Once you're established, we can help schedule follow-up appointments, check stock at different pharmacies, or address pharmacy issues. If you need treatment verification letters for whatever reasons, for courts or for your employer or whatever, we can do those for you. Your urine drug screens, we filter those through. If you have questions, problems with those, we can answer those questions. Updating your personal information, you got a new phone number, you moved or something. If you seem to be you feel like you're having an interaction with something, or you're having some new symptoms that's different for you, we want to know about it. Tell us about it, because we can help with that also. The list goes on and on about all the things that we can help with. And of course, if we need to reach out to your provider for urgent medical issues, we absolutely will. We absolutely do. And you also have access to your provider as well. If your provider's out of the office, there are on-call and covering providers that are also available. And while we are behind the scenes, though, behind the computer screen, we are here to support you. We're here to listen to your concerns. We're here to celebrate your successes, but we are also here to help hold you accountable. Now, I was mentioning your care team. It's not just me. It's not just Dr. Craig. Your care team is comprised of medical personnel, but it also includes highly innovative tech support and engineering that's always looking for ways to improve the overall app experience. In the age of technology, we all know things happen, right? The highly skilled team, they're here to help resolve these unforeseen tech issues that do sometimes happen and get things back on track as quickly as possible. We also have a dedicated financial management team, whether you're a self-pay patient or an insurance pay patient, to make sure that your billing is accurate and as absolutely painless as possible. Again, we understand things happen, life comes up. You may need to reach out to us for a billing question to change your billing date, or request maybe some other financial options that you might qualify for. Anything, basically any question that you have, send it to us in the app, and we can either answer it on the spot for you or get you to the department that will be able to have that answer for you. Now, we mentioned before that MAT, the medication assisted treatment, is not only about medication, but it involves treating the whole person. And that, again, does include our mental health. Because of this, you also have access to one-on-one licensed therapist, group therapy, peer-led support groups, and care coordination. Some of us have been where you are. Some of us have been on the outside and looking in. If you're not comfortable at first talking with a therapist one-on-one, or just talking in general, go to a support group, go to a therapy session and just sit and listen. You don't have to talk. There's so many different groups, all walks of life, every day of the week, all hours of the day. Every person in there has a story. And one of those stories might actually resonate with you. You might see yourself. I know this experience, what you're going through sometimes feels like you're alone and nobody knows what you're feeling. But we do. And somebody in that group might also, and their story might help you, but your story might also help them. So I just encourage, just try at least one. You might actually just find that you like it. Thank you so much for listening. I hope to see you in the chats. And I'm actually going to pass it over to Kyle to introduce the next section.
Awesome, Gina. Thank you so much for that. And thank you, Dr. Craig, as well. You're both so appreciated with great information. So our final speaker of the evening is going to be the talented Robin Carter. Robin is going to go over Bicycle Health's enrollment process with you and just talk about how easy it is to join the Bicycle Health program. Go right ahead, Robin, whenever you're ready.
Thanks, Kyle. Hi, everyone. My name is Robin Carter, and I'd like to go over Bicycle Health's enrollment process with you. I'll go over the different options we have to enroll into our program, and then I'll go over the additional steps needed to become an established Bicycle Health patient. To start, we have multiple ways you can choose from to enroll into our program. From our website, you can actually find a chat functionality that will connect you with one of our enrollment coordinators, and they'll walk you through the entire process. Also, from our website, you have the ability to go on and schedule the perfect date and time for one of our enrollment coordinators to reach out to you. Or you can choose to enroll through our self-service option, which would involve you filling out an intake on your own and having an enrollment coordinator reach out to you once it's completed. You can also call straight into our phone lines. Once you connect yourself with an enrollment coordinator, they'll introduce themselves, go over the program information, as well as answer any questions that you might have. They'll speak with you about our $199 monthly rate, which covers all doctor's visits for that particular month, access to online support groups, access to a care team, and all of your urine drug screening kits. Once questions are answered, the enrollment coordinator will go through about a 10 to 15-minute health questionnaire with you. This questionnaire will help us gather basic information on you to help determine if Bicycle Health is going to be a good fit for you and you'll be a good fit for Bicycle Health. Of course, all information gathered will be kept completely confidential. During the questionnaire, the enrollment coordinator will also go over billing options with you, such as if you have any insurance, going to be self-pay. We are able to accept many commercial insurances, and in some states, we're able to accept Medicaid and Medicare. Once the questionnaire is completed, the enrollment coordinator will electronically send you the paperwork via text or email that will need to be filled out. These are just standard forms that you'll fill out when you go to any kind of doctor's office. There's a consent form, a financial agreement, as well as a couple of HIPAA forms that will need to be filled out as well. You'll also upload a photo of your ID, and if you're paying for treatment with insurance, you'll upload an image of your insurance card as well. At the time we receive your completed paperwork, we can then get your appointment scheduled. We'll book your first initial appointment. This appointment is going to be an hour-long slot, so you do want to keep that in mind. After we book your initial appointment, we'll then book your 20-minute follow-up. This appointment is simply so that your provider can check in on you, see how you're doing, see how you're feeling, things like that. Your follow-up appointment will be scheduled anywhere between 2 to 7 days from your initial appointment. Now that your appointments have been scheduled, your paperwork will go into processing. Our enrollment team will assist you through the registration process and ensure that everything is set up for your first appointment. Once our team has finished processing all paperwork, we'll go ahead, send you the Bicycle Health app to download onto your phone, and all you'll need to do is just wait for your appointment date and time.
Awesome. Thank you so much, Robin, for that. I mean, we at Bicycle Health, we certainly do our best to, make joining our program as easy and seamlessly as possible. And Robin, thank you for taking the time to go over that with everybody. You're the best. So before we start taking questions from you all, we would like to just take the next few minutes to give you a brief demonstration of our Bicycle Health app so that you can see all of its, functionalities, its simplicity, and really just how easy it is to navigate. So I hope you guys enjoyed this little video.
Welcome to the Bicycle Health app. The first tab is the home screen. It shows me everything I need to know about what's coming up with my treatment. I can see my upcoming appointments as well as any clinical tasks that have been assigned to me by my provider. We'll talk more about clinical tasks in the second part of this video. In the Appointments tab, I can see all past and upcoming appointments. Throughout the Bicycle Health app, I can contact my provider or a member of the Bicycle Health admin team anytime by tapping the chat button in the bottom right corner. In-app chat is organized into channels, so I can direct my question to the most appropriate team. In the Meds tab, I can find up-to-date info on my current prescriptions and preferred pharmacies. Under the Resources tab, I can access my account information and settings as well as information and tools. I have an appointment coming up, so I'm going to test out my microphone and camera. Looks good. Now I'm just going to make sure all my app permissions are set up properly. If I have any questions, I can open up the FAQ section and browse through to learn more about different parts of bicycle health treatment. Finally, I can update my payment information and confirm that all my contact info is correct. At this point, I can join the video call from my appointment. I can join the video call up to 30 minutes before my appointment is scheduled to start. If for some reason I get disconnected from the video call and I want to rejoin, I can do that by tapping the Rejoin Appointment button. During my visit, my doctor told me about support groups that are hosted by are group video calls that happen on set days and times. I can browse through the list on the home screen and find support groups that are most convenient for me. If I join them, I'll receive reminders when they're about to start. All I have to do to jump in one is open up my home screen and hit the Join Video Call button. When I join a support group, I know I'm going to be joining a video call with other peers who are also going through recovery. The Bicycle Health app lets me set my privacy settings to choose how much of my full name, if any, I want to display to other peers in that support group.
All right, so that's a bit about our app and how the app works. You can see it's pretty user-friendly and there's a lot of functionality that you can do in there. All right, so we'd now like to spend these last few moments. Looks like we have about 11 minutes left. So we'd now like to, like I said, spend these last moments being able to answer any questions that you may have. So if you have any questions, please post them in that QA, and Robin and Gina and Dr. Craig will do their best to answer those questions for you. So feel free to go ahead and enter in your questions, and Robin, if you don't mind reading the questions out loud, and then just providing your answer as well.
Most definitely. Alrighty, so we have a question from David. What do you guys do when a patient cannot connect to the Zoom call? Do you refer them somewhere else? So as an enrollment coordinator, we do a really good job of ensuring that all of our patients are able to connect to their Zoom appointment prior to their appointment. We make sure that they're able to get into the app, have it downloaded, registered in the app. Now, we do have technical issues. If you do ever have any issues and you can't connect to the Zoom appointment, any of our ACs can give you a call and kind of walk you through how to connect to the Zoom. Your provider will also kind of let us know, hey, this patient is having an issue logging in. We'll give you a call and we'll assist you with that.
I would actually also like to answer this question just from the CSS side of it. If you're already an established patient and you log in, it's actually kind of the same thing. We do recommend that you try to log in a few minutes early just to make sure that everything's working properly. And if it's not, like, again, things happen. We do have a technical support chat channel and also your medical team channel that you can send us a message in one or the other so that your provider is aware that you're having technical issues, and we can send that straight over to the engineers to help resolve the issue immediately so you don't miss your appointment.
I can answer from the point of view of a medical provider also. If somebody that we know and is reliable can't get in once, we will try to call them, try to work them back into the video call. And if not, we can sometimes do one appointment by audio if we know the patient. If it's a consistent issue where the person is in a location where they just can't get on Wi-Fi or they can't get enough data signal to be able to use the technology, brings up the question of whether they're right for this particular program. We understand sporadic issues. I have them too. I live in rural New Mexico. It's frequent that I have internet issues, free backup signals just in case. But we really need people to be able to get onto that. If there's a tech issue once or twice, we will call them and try to work things out that way. It looks like that next question might also be for me. It says, in some stay on Suboxone for life, is there typical cadence of when one tapers off, or how typically handled? I'll go ahead and answer that since I think that's probably for me. It's highly individual. It depends. How long people are on Suboxone is their choice. We really discourage short tapers, because when we do short tapers, it used to be common to do like a 7-day taper in rehab and then kind of send people out. The rate of relapse at that point is closing 100%. People who stay on Suboxone for less than a year, 95% of them go back to opioids. Now, there's a broad range. I've had a few patients, which is really where we want to see people. Somebody who had big surgery or big accident 3 months ago, and they're realizing it's really hard to get off opioids, and they continue down that road. They don't want to wait until things get bad and worse. And they go on to Suboxone, do a fairly short taper over a week or so, and they're done and move on with their life. That's pretty rare. I've done it a couple of times. We have people on the far end who stay on it for a lifetime because of the duration that they've been on it, chronic pain issues, that kind of thing. Most of the time, we recommend people stay on it for 12 months. I've long since come to realize that I cannot tell patients what to do any more than have a conversation and advise them. So if somebody wants to taper off on their own at home, they will do it regardless of what I say. But we have a lot of back and forth about how to do that the least painful way. I do it very, very slow tapers, something like 1/4 milligram a month. It takes a couple of years to get off of it, but the goal is that they don't feel it, that somebody's not feeling the withdrawals, they're not feeling the cravings, that their body's able to make those adjustments to their physiology, including how many liver enzymes they have that are cranking through that medication, how many opioid receptors they have accessible to let that settle back down. People who've started very young, I've had patients who started, we have kind of a unique opioid situation in northern New Mexico. Patients have started as young as 10, 11. Those folks have a much harder time. Their brain was kind of developed around this idea that, well, there's this high level of opioids, that are kind of around, and that's normal, and their brain develops with that in mind, and literally in mind. And those folks are much harder to get off opioids. There's also people who've just been on them for extremely long periods of time. On the very far end, I had a gentleman in his 70s who had been on heroin for 50 years, 50. I don't know how he survived it, but he did. When he finally went on to Suboxone, there will be no tapering at that point. He was going to live and die on it, and may have passed away by now. That was almost 10 years ago. And in between, it's highly individual. If people are tolerating a taper well, we'll continue. If somebody's not tolerating it, there's always the option to go back up to a higher dose. In my practice, I never force people to taper. If somebody wants to, I let them kind of work on that at home. When they're at a substantially lower dose, I will then follow them with a prescription that matches that, but I'm not going to push that prescription down ahead of their need, partly because I don't want to deal with the pharmacy when they run out early. I've made the decision that that's not going to be part of my life, but also because we don't want to put patients in a position where they're having to choose between taking extra, which is not advised, and going back to opioids. Hope that answers the question. I also see another question I might be able to answer. Do we keep statistics on the success of this program, and what does that look like? Retention rate is one of the key measures that we look at, and I can't, there was a time at which I had them committed to memory, but they are also changing all the time. We beat the industry standard for retention. Retention is one of the most difficult things with opioid use disorder, and the reasons for lack of retention range from things like can't afford the program, move and lose a provider. I literally had a number of patients during COVID who said, I'm in trouble because my provider died of COVID. There was that era when a lot of healthcare providers were really suffering with COVID. So in general, our retention rates are far higher than industry standard, but I couldn't give you the exact numbers right now off the top of my head.
Dr. There was actually a follow-up question to that. What is the industry standard for retention? Do you know what that looks like?
I don't. There is a paper that I can send a link to Kyle, and he can send it out if we have an email address to send it to. We actually have some published data on that, but I don't have it in mind right now. I can get that out to somebody if they're interested, though.
Yeah, just to piggyback off that, once this is over, there's actually an email address I'll provide you all with that we can continue to communicate.
Somebody asked, how soon can a patient get their first appointment after making a call? I know Kyle and Robin can actually better answer that question, but I think Robin actually mentioned our goal is, 2 to 7 days after initial. It depends on a whole lot of things, provider availability and insurance and completion of intake paperwork and all those sorts of things. But we do try to get our patients in as soon as possible. We're constantly adding new providers, constantly adding new states, new insurances. So we're getting a lot better.
Due to quick Googling, I was able to find the published results we have. These are probably over a year old at this point. I'm going to send the message under David D's question there. Let's see. Since I'm already talking, I see one says, I want to do group meetings, but I'm concerned about my privacy and how comfortable I'd feel about doing it on Zoom. I think that one of the nice things about telemedicine is that a lot of our peer recovery support coaches, they're not state specific. So if you go to an NA meeting, you're going to walk into a church basement or a rec hall or something, and you're going to see whoever in your community has issues. Now, there's advantages to that. That might be somebody that you really relate to, that they can relate to your geographical location and the local culture. There's a downside, though, which is you may know those people. Those people may know you. That may be somebody you see in a grocery store. That may be somebody you work with. It may be somebody in your life that you didn't know had an issue. The nice thing about these cross-state support groups is that the chances of running into somebody you know are highly unlikely. And I would let Sarah answer, are people allowed to keep their cameras off and their name anonymized during those support groups? That's my question for Sarah, because I'm not sure.
Absolutely. So we just need to verify that the patient is who they say they are, right? So we have ways to keep things anonymous. And as long as you let Bicycle Health staff know that you are there and you are who you say you are, we have ways to anonymize it. And we actually encourage it. We also have one-on-one offerings from both therapy and recovery coaches. So if you aren't comfortable going to support groups, you could also meet one of the recovery coaches or therapists one-on-one. And what some of our recovery coaches will sometimes do is meet with people one-on-one and then help kind of acclimate them into the group and bring them in if they're comfortable doing so. But as Dr. Craig said, we have a very large geographical region, and it's been really neat to watch the support groups come alive, because there's like a really special camaraderie and family unit in there. And obviously in a support group setting, we can't guarantee that you would never, know anyone kind of thing, but it is much, much rarer. And the folks who we have attend have guide roles that they follow pretty closely. And so your anonymous or anonymity is very important to us, and we do everything we can to safely maintain all patient safety and for people to feel as comfortable as possible.
I would actually just like to piggyback on that also, kind of again from the CSS side of it. The chats in the app are actually part of your medical record. The app is secure for those reasons. So your meetings are held, they are held through a Zoom meeting, but it's through your app. And so your app being secure, because again, this is all part of your medical record since we're telemedicine. We do very much pride ourselves in, keeping the HIPAA compliance for our patients and anonymity. And actually just wanted to answer another question that's here. If someone tapers and leaves Bicycle Health, can they rejoin the program? And that's actually where me as a CSS would come into play for you. So yes, absolutely. As long as you were, compliant with the program, there's, no other outstanding issues why you would not be able to rejoin the program, then yes, absolutely. We do have you fill out a little re-enrollment packet. It's nothing like the intake paperwork. It's just more or less verifying your address, phone number, insurance, if you have any, that type thing. And then once that's filled out, we can get you set back up. So absolutely.
And I would add to that also that one of my big beefs with Alcoholics Anonymous, Narcotics Anonymous, and that model is the idea that you have to hit rock bottom before you turn around and get help. Now, much easier said in an era where we have medications, which was not the case when AA was founded. We don't want people to hit bottom. I would rather catch somebody when they start to realize that they're running out of their narcotics from their doctor early on a consistent basis, before they lose a job, before they go to street fentanyl. And I feel the same way about relapse. It's not if somebody relapses that they should come back in. It's if they think they were going to relapse. If they start to think, you know what, it's around me all the time. I'm getting pulled to it. I'm having a very stressful time of my life. We absolutely want to see people back rather than relapse. That is 100%. So absolutely, people are welcome to rejoin if they taper off, or if they leave for any other reason, including, moving into a state that we don't serve and then moving back to a state that we serve. Any reason why people would want to rejoin. I do want to say one thing. I think that last question, I think that telemedicine is one of the great leaps forward in helping patients to avoid the stigma that goes along with opioid use disorder. In a better world, that stigma wouldn't exist. But I've been in many models where we tried to avoid stigma by mixing things in with primary care so that it's kind of seamless who's coming in for buprenorphine and who's not. I have been in models where on Tuesdays, everybody who walks into the building is on Suboxone, and that's so that they have their own space and their own time and don't have to deal with judgment from other people. And that makes it very obvious to everybody in the community that everybody who walks in on Tuesday is on Suboxone. So I think that until stigma is resolved, which I don't really see happening soon, this is very much a way to get the services without having to go into a building, without having to take frequent time off work, all the things that kind of mark people as having a substance use disorder. So I just want to emphasize that one of our big pushes is to avoid that stigma in any way that we can.
Absolutely. And to echo that sentiment, think too, my big thing is always that dead people can't recover, right? And that medications for addiction treatment may be imperfect, as Dr. Craig went over earlier. But that being said, if it helps you live a higher quality and better quality of life, that's all that matters at the end of the day. And our loved ones, if they're supportive and positive protective factors, can hopefully be educated. And we do absolutely do CBT. We can do cognitive behavioral therapy. We have some cognitive behavioral therapy focus groups, and a lot of our therapy teams also trained in CBT. And research indicates that CBT, cognitive behavioral therapy, is actually a really good way to look at your thought processes and identify triggers and to have better coping mechanisms and looking at how we think and why we're thinking the way we are. So we absolutely do so.
So the next question I see is, how much does this service cost? It actually, if you are self-pay, it is only $199 for a 30-day subscription. It's billed monthly, and that includes all of your medical provider visits, whether you see your provider once or 17 times, whatever, you agree upon. It also includes your support groups. We do send out your urine testing supplies. So it includes the cost of those as well. Gosh, what else? Us. You get to communicate with us all day, every day. Yeah, so it includes so much, like $199. That's like completely unheard of. And if you're insurance, then we bill the insurance. Then if you have copay, co-insurance, deductible, that type thing, then you will end up getting an invoice from your insurance for whatever your portion is. It's usually about 30 to 45 days after your visits that you get that from your insurance company.
Yeah, and just to piggyback off that as well, excuse me, the group sessions are also all included in that $199 a month. And the only thing that's not included in that $199 a month would be your prescription. And the reason for that is just because the pharmacy is really the one who chooses those prices. But what we do have, if you are a self-pay patient, our pharmacy team, who is part of Gina's team, we are able to offer, we have a contract with Optum Perks, which is very similar to GoodRx. If you've ever heard of GoodRx, it's very similar. And it really cuts down the costs of those prescription prices. So again, within that $199 a month, we want to make sure you're getting everything that you possibly need for your treatment purposes.
I would throw one other thing in there, which is private counseling is billed separately. So if as the medical person, and if you see me once, it's $199. As Gina said, if you see me 20 times, it's still $199, which is, I think, the most important thing. You're predictable. It's predictable. It's going to happen every month. It's not like, well, it's $350 for the first visit, and then $200 for each next visit. We want to see you weekly for the first month, and then, on and on. I want to answer a little bit about my employer. No, and I'm using my work insurance for treatment. That is a little bit of a hard question. In general, that's bound by privacy, but that is highly dependent. There are some employer, like large employer groups, that are self-insured. Your information should be protected, but that's really something you want to investigate with your insurance before you would enroll. And do we offer Suboxone or other medications? So there's 3 FDA-approved medications for opioid use disorder. Buprenorphine is one of them. Buprenorphine naloxone. We only use that dual form, the buprenorphine naloxone, not the solo buprenorphine. That's a whole big political thing. Methadone has to go out of a methadone clinic, so we're not able to use that. And we are looking at innovative ways to engage with Vivitrol, which is an injection of what amounts to Narcan that lasts for a month. It blocks people from being able to feel the effects of opioids, protects them from overdoses. It's not great at addressing cravings and withdrawals. So we're looking at ways to be able to do that. We don't have physical locations, so that would have to go through a pharmacy. So we don't have that yet, but we may in the future. We also have a wide variety of other medications that we use.
She said she has Wi-Fi issues sometimes.
She did mention that. Sarah or Gina, do you guys kind of know where she was going with that, where we may be able to help answer her?
So with as far as like the medications go, it is Suboxone is like a brand name of buprenorphine naloxone, which is the main one that we use. I've only seen a couple of providers using the Vivitrol, like she had been talking about. The Suboxone, from what I've seen, through the chats and, appointment notes and things, is like she said, the Vivitrol doesn't help with the cravings and things. So having the Suboxone, using that for right now, from what I'm seeing, seems to still be the top choice. So
Suboxone is our primary tool, but and we can't do methadone, but usually if we can do it safely, our clinicians are always willing and wanting to do it. And I don't know if that question was also overlapping like other medications outside of opioid use disorder. Some of our doctors will also prescribe some what I call like psych meds light. So if they're comfortable doing so and have met clinical criteria, they may be willing to do some light, antidepressants or things of that nature. But, Dr. Craig could speak more so to that. But usually if it's more intense psychiatric medications, we'll refer out and work alongside psychiatry. We do not do usual kind of PCP-like medications or other medical medications that I'm aware of. Our real wheelhouse is treating opioid use disorder. And as was said earlier, I know you have to go to a clinic for methadone. Our primary wheelhouse is the Suboxone, but we will explore other things if we can do it safely and effectively.
Awesome. All right, folks. Well, we are at 10:11 Eastern time, so our time has come to end our open house here. If you do end up, though, having any further questions, you can actually send all of your inquiries to an email address, openhouse@bicyclehealth.com. And just to reiterate that, that's openhouse@bicyclehealth.com. And we're going to respond back to you as soon as we possibly can. If you are interested in enrolling into our program or know of anyone that would be interested in our program, you can also call us at 844-943-2514, extension 1. And again, 844-943-2514, extension 1. You can also visit our website, pretty easy, bicyclehealth.com, where you can review the other enrollment options that Robin spoke about, such as our chat enrollment, which is becoming very popular. I would like to thank you all so much for taking the time to learn about Bicycle Health and what we're all about. I would also like to thank everyone involved that assisted with putting this event together. Thank you all for all that you have done, for all of your hard work and dedication to put this on. I hope all of you guys have a fabulous night. Have a great weekend. Be safe. And thank you for your time. Have a good night, everybody.
Thanks for coming, guys.